This is Hadi Lichaa, interventional cardiovascular specialist, recording this video on optimal access of an antegrade, common femoral or superficial femoral artery for infrapopliteal peripheral vascular intervention. Some operators still stand on the right side of the patient even if the access is in the left common femoral artery retrograde approach. This not only exposes the operator, as shown on this figure, to a massive amount of radiation since they're almost hugging the image intensifier, but also orthopedic issues with back pain since those procedures are prolonged. One option is to move to the left side, but this addresses the issue about screen position, controls, and shielding. So after years of experience, we thought that flipping the patient's position to the cranial caudal position would favor multiple aspects. Number one, we're far away from the radiation. As you can see here, you're almost 6-7 feet away from radiation, which massively decreases radiation exposure. The support is optimal. The torque transmission for very long wire and equipment is optimal. The reach is not an issue anymore since we don't have to worry about the length from the contralateral access. Transcollateral work is possible since obviously this requires a lot of length. And if the patient has a very tortuous calcified iliacs with an acute bifurcation, this is taken out of the equation with regards to possible morbidity of the procedure iliac injury. The halo device on the head of the patient is essential to keep that drape off the face, and it's important to carve out some space to be able to work balloons and over-the-wire equipment alongside the patient. We thought this is a practical approach that saves a lot of problems.